Thank you so much for joining us. I am Dr. Will Fenton, Director of Scholarly Innovation at the Library Company of Philadelphia. If you haven't heard of the Library Company, there are many ways I could introduce it. Going back to when we were founded by Franklin in 1731, we were a subscription library, which was really the sort of basis for a lot of the work that was done on drafting the Constitution. And we served as the first Library of Congress. But I would say that the 20th century story is probably most relevant to where we are today. That's when we sort of reconstituted ourselves as a research library, with specializations in a number of different programs, including early American literature, history and print culture, women's history, the graphic arts, political economy, and of course, our crown jewel of programs, our African American history program. And this seminar is really associated with that African American history program. We have this amazing Mellon Scholars Program that has just culminated, but we actually have a couple of the scholars that have joined us along with our speaker today. Our seminar series more generally is really intended to give our community an opportunity to get up close and personal with our collections. And this is a little bit of a departure because we can't pull out a bunch of old books and political cartoons and engravings in our reading room for obvious reasons. But the benefit here is that we can convene folks from all over the country, including our speaker who is actually at Houston. And we can also do this online and for free. And so I would like to invite you here to a Zoom webinar. This means that your camera is not on. We don't see you, so you can put up your feet and relax. You don't have to worry about your hair. And of course, you can participate through the Q&A feature. So if you scroll down to the bottom of your screen, and cursor around the bottom, you'll see a Q&A button. And I encourage you, as you're listening to what promises to be a fascinating talk in our Racism and Infectious Disease seminar, to pose your questions before you forget them. If you're anything like me, if you don't write them down, they just vanish from your mind as soon as you move on to the next thing. Of course, we will follow up after the fact with a durable link to this seminar. We put every seminar up on YouTube, which means that you will have a video link that you can share with your friends and colleagues who might not have been able to join us today. And we'll also follow up with any session notes. So if I think of anything clever along the way, I will share it through the chat functionality, and then we'll just compile all of that into one package for you that you'll get within the next week or so. So with that, I want to, or I should say, it is my pleasure to introduce our speaker today. Dr. Richard McKinley Mizell Jr. is Associate Professor of History at the University of Houston. He's also the Director of Graduate Studies in the Department of History. His research focuses on historical understandings of health and healthcare politics, medical citizenship, environmentalism in health, medical technology, race, gender, and ethnicity in medicine, and the transformation of disease identity. Dr. Mizell is the author of Backwater Blues, the Mississippi Flood of 1927 in the African American Imagination, which was published by the University of Minnesota Press in 2014, and the co-editor of Resiliency and Opportunity, Lessons from the U.S. Gulf Coast After Katrina and Rita, published by the Brookings Institution Press in 2011. Thank you so much for joining us, Richard.
Thank you, Will. Let me thank you once again for inviting me, as well as Deirdre Cooper Owens. And let me also thank Jasmine Grant, who I failed to thank last time I was here a couple of weeks ago for all of her help in putting this together. I'm excited to be here and have this conversation with you about some of my research from the past, but also some of my research moving forward. I want to begin with a little bit more of a sort of biography of sort of my interests. Just very quickly, I did write a book on the 1927 Mississippi River flood, which prior to Hurricane Katrina was the worst environmental disaster in American history. But as a background, I'm interested in the history of medicine, race, environment, and technology. And so those fields, those ways of thinking converge in my research and how I think about questions of environmentalism, but also how I think about questions of race and disease and public health. And as a historian, I've always been fascinated by what environmental disasters as well as pandemics tell us about a particular place and time. In other words, disasters mark time, right? We remember life before a particular disaster, and we like to recount, what changes have occurred in society after a particular disaster. That's part of the human experience to recount through trauma. Human beings have always been fascinated with trauma. Disasters have always been a medium, portal of which sort of change has occurred. But these disasters also sort of tell us something important about race, class, gender, as well as politics. I think about some of the work on, for example, the 1906 San Francisco earthquake, which Californians sort of marked that particular disaster as an important turning point in that state's history. But the politics of the 1906 San Francisco earthquake were important for a number of reasons. The least of which was not the least of which was this sort of debate over how many people actually died during the disaster. And so you see this constant reevaluation of death and what's to blame for these deaths. For a long time, for example, there was a debate after the San Francisco earthquake as to whether it was actually the earthquake or the fires that was the result of the earthquake which caused deaths. And there were particular reasons that politicians wanted to sort of tag the fire as the real cause of that particular disaster. It seemed less risky. You could control fires a little bit more. And they were more predictable, right? So these disasters in that way tell us something important about a particular time and place and space as well. But I'm also interested in these questions of local and federal government for disasters. Part of my work deals with disasters and the state, which, as it turns out, tells us something very important about this moment in which we currently find ourselves in. Most people don't know that it really wasn't until post-World War II in the 1960s that the federal government played a large role in helping individuals deal with disasters. Prior to the 1960s and 1950s, the federal government may have opened up the treasury, but it was mostly in the form of helping to rehabilitate landscapes, buildings, infrastructure, bridges, roads. Early 20th century disasters were mostly local enterprises. If there was a tornado in Kansas or a hurricane in Florida, that was a uniquely specific local disaster. Outside of the Red Cross, who may have generated funds from across the country, most individuals living within a particular state in the early 20th century really could not expect assistance from the federal government. So in that sense, these were local disasters. And it really wasn't until a spate of tornadoes and hurricanes and an increased emphasis on this post-World War II that the federal government began to sort of take shape and deal with people in the aftermath of an environmental disaster. And that's important for pandemics as well, as it turns out. Part of the criticism of response after the 1918-1919 influenza flu pandemic, for example, was that each individual state, each individual community dealt with the pandemic on a local way, and there was not much in the form of uniformity from the federal government. So environmental planning, as it turns out, then tells us something very important as well about how we think about pandemics and epidemics and how we might think about the local as part of a much broader sort of identity, connection between different groups of people and spaces. So that as a way of introduction, I want to do three things in relatively short order with this presentation. First is to talk a little bit about diabetes, just very quickly, and some of my research and findings on diabetes and Hurricane Katrina, And finally, sort of thinking a little bit of coda on COVID disaster and how we might think about disasters and the colliding of two particular disasters. So start officially the presentation here. So what happens when disasters collide? And I must admit, I spent quite a bit of time on these images, thinking about the images, probably too much time. The top image is a well-known image of a flood wall in New Orleans, Lake Pontchartrain. The flood waters that came across that flood wall in 2005 in Hurricane Katrina. The bottom image is one of my favorite images, which highlights food deserts and medical deserts and dental deserts as an illness, but also a social, political aspect of environmental planning, urban infrastructure, and the disease and comorbidities that these deserts might cause. And so diabetes in many ways sort of speaks to this broader narrative of space, race, place, and how we think about these questions in relationships to other disasters, but also the unique historical experiences of diabetics throughout the 20th century. So these statistics of diabetes are fairly well known to people now. Just recently, in the last 2 years, the World Health Organization wrote that 16 million people in the United States suffer from diabetes. The CDC argues that by 2025, 270 million people worldwide will suffer from diabetes and its complications. These are massive numbers. These are numbers that are important for us to contextualize and think about what this means in terms of health expenditures, what it means in terms of hospitalizations, what it means in lost wages due to premature death, but also what it means in terms of how other individuals, family, friends, how their lives are altered when thinking about diabetes. So I wanted to give just a little sort of brief background of diabetes. Diabetes is an ancient disease. One of the first sort of references to this disease known as diabetes dates to an ancient Egyptian text called the Papyrus. Egyptian physicians wrote of a disease in which the body seemingly melted away into water. The term diabetes dates to roughly the 2nd century. The term diabetes comes from the Greek word of siphon, as if water and urine are being siphoned through the body like a funnel. To this day, 2 of the ways that we diagnose diabetes is polydipsia, which is excessive thirst, and polyuria, which is excessive urination. Diabetes was known for quite a bit of time as a disgusting and painful disease, a disease where water and urine just seemingly would run through the body in a painful way. The secondary term of diabetes, which the major secondary term of mellitus, dates to the late 1600s. And the writings of an English physician by the name of Thomas Willis, who wrote a treatise called Diabetes, or the Pissing Evil. And the pissing evil was how diabetes was known for a number of centuries. But as part of this book, Thomas Willis described tasting the urine of a diabetic patient and saying that it resembled honey or sugar, or that the urine of this diabetic patient was sweet like honey or sugar. Now, all across Zoom land, I can see people cringing just by saying that, but prior to the 20th century, tasting bodily parts, urine, sweat, was one of the ways that physicians diagnosed disease. And mellitus comes from the Greek word meaning honey or of a sweet nature. So by the beginning of really the 18th century, you have this term of mellitus being attached to diabetes. Today, we think of type 1 diabetes as a B cell or beta cell pancreatic disorder. The pancreas is part of the body's communication system, and insulin is part of the body's communication system. Pancreas is the major producer of insulin. Insulin circulates throughout the body via the bloodstream and sends signals to organs that the blood is rich with nutrients. When insulin, as a type 1 diabetic, fails to be produced, then external insulin is required to prevent the buildup of glucose in the bloodstream and toxic materials. Traditionally, we think of type 1 diabetes as juvenile onset diabetes because most of the people who were considered to be type 1 were young, either at birth or were diagnosed fairly early in their lives. Type 2 diabetes, or what's considered to be adult onset diabetes, is the result of signaling mishap, so to speak. Insulin is perhaps produced by the pancreas, but over time, the signaling becomes murky and organs and systems in the body do not hear the signaling coming from insulin. The body will respond by producing more insulin, which might deal with the problem for a temporary time. But over time, for some people, the signaling system no longer works. Either the body stops producing insulin altogether, or there's a continued gap between what insulin is signaling and what organs in the body can hear. And at that point, type 2 diabetics might also need external insulin as well and move from being insulin resistant to insulin dependent. Those people are considered normally type 2 or adult onset because the symptoms of this particular form of diabetes might emerge after the age of 40. Now, part of my research sort of complicates this by thinking about questions of where this sort of terminology of type 1 and type 2 comes from, but also what are the politics behind type 1 and type 2 and how people we often think of type 1 as type 1 might actually be type 2 and vice versa. So these then are important questions for us to think about in relationship to this. One of the earliest individuals in the 20th century, at least, to deal with diabetes was Elliot Joslin, who wrote the first textbook really on diabetes, the treatment of diabetes mellitus. Joslin became interested in diabetes as a graduate student when his aunt became ill with diabetes. And he realized at that point in medical school that he really had no idea what diabetes was, how one got it. And he decided to use his life as part of the research to sort of think about this mysterious disease. And Elliot Joslin was among a cadre of physicians and scientists who really began to focus in on the diet of diabetics, really sort of thinking about sort of cholesterol levels, sugar intake, fat intake as a way of sort of squeezing out the worst aspects, as he would say, of diabetes. Now, this image is important. This is sort of one of the images that I use in my book that I'm writing now on diabetes. This comes a little bit later in the 1940s in a diabetes publication called The Forecast. And I could spend quite a bit of time sort of talking about this particular cartoon, but I will sort of bring out a few points, because in some ways this one cartoon sort of narrates many of the important issues of diabetes. but also how it connects to these questions of environmental disasters. Diabetes, what is it? There's still some misunderstanding of what diabetes is. And part of what separates diabetes from other chronic diseases is this sort of terrain of sort of knowledge in which we're continuing to sort of seek information, or don't have a complete understanding of how diabetes evolves. In many ways, what are the reasons for the signaling problems within type 2 and sometimes type 1 diabetics? For most of the period before the 20th century, the perception of scientists was that diabetes originated in the cardiovascular system. By the late 19th, early 20th century, it was tied to the endocrine system. What is the emphasis of stress on diabetes? How is type 1 diabetes different from type 2 diabetes? In fact, throughout the 1950s and even before, there was sort of these interesting conversations around diabetes and eugenics. People believing that there was a sort of eugenic factor to diabetes. But also, sort of more recently, sort of African Americans have really begun to mobilize around type 1 diabetes and their status, arguing that the perception is that African Americans do not suffer from type 1 diabetes. And in fact, about 10 years ago, there was, and continues to be, this conversation of a diabetes war, in which type 1 diabetics want a different status altogether, and in many ways a different name, arguing that type 1 diabetes is altogether a different disease than type 2 diabetes, and that when we think about diabetes, the perception is that it's type 2 diabetes that can be reversed. And type 1 diabetics would argue that their condition is not temporary, that it cannot be reversed, and that they are not being given the scientific research dollars and attention that type 2 diabetics are. So there's, all of these sort of questions of diabetes that continues to evolve through different times and different spaces. Top right, the symptoms are, excessive urination, excessive thirst. You have the one image of this particular person running to a physician. Sort of questions of, diabetics who do not have access to physicians historically, being misdiagnosed, right? All of these questions are elevated or raised in this particular image. The perception is that you might take the perception of this particular image as this person being a type 2 diabetic because of their portly figure, but he could very well be a type 1 diabetic, right? These are the questions, right? So you can take assumptions out of this particular image, but it does not necessarily fit with what sort of science is how science is evolving through different time and different places. Some simple but rigid rules. Part of what you see in the patient archives of diabetics from late 19th century to yesterday is struggle with the rules of being a diabetic, which means eating on time, eating the proper foods. Early 20th century patient records are full of stories of children eating cake when they're not supposed to, or parents being annoyed with their children for eating cake when they were not supposed to, or drinking something that they were not supposed to when they were out of their sight. This is, something that of course children will do, but also adults who were tired of eating the same monotonous diet day in and day out to deal with diabetes. But these rules were posed to them as the way to deal with this particular chronic illness. But also insulin, when insulin was discovered or became available in 1922 to 1923 to a very limited number of people and beyond, injecting oneself with insulin was a laborious process. In the early days, you would have to do it several times per day. People didn't really know what they were doing, how to inject themselves with insulin. The needles were sensitive and they would often break, so they would have to continue to stick themselves over and over again, sometimes 10, 15 times a day to get it right. People would spill and break the insulin. And so it was a complicated lifestyle that people had to deal with in the early 20th century and continue to have to deal with. And there's also the family element. The patient archive is full of conversations around children whose siblings had diabetes and the frustration they had and not being able to eat what they wanted to eat because of their siblings, or being frustrated because they felt like people were judging them for sort of eating certain foods around their sibling. The same thing with parents, and the same thing with siblings, as well as spouses as well. You see the image of the person sort of eating or at a restaurant, presumably. So it's diet was an important part. And the bottom left, don't risk any complications, which is an important part of the chronic status of insulin. Once the insulin revolution changed diabetes from an acutely deadly disease into a chronic long-term disease. The risk of complications due to breaks in the skin, due to complications of kidney failure or heart disease, all of these things could be particularly deadly. And on the bottom right, the rest of my life will be as good as anyone. There was this narrative put forth by Jocelyn that diabetics were in some ways sort of chosen patients in this sort of narrative of worthy and unworthy in terms of suffering. So the complications, the rigid rules are very important in understanding this history of diabetes. So how do we think about this in terms of Hurricane Katrina? Hurricane Katrina was, as you remember, a Category 5 storm that hit New Orleans as well as the Gulf Coast. Katrina was, in many ways, a shameful episode in U.S. history. It was a colossal failure of local and national government, of local and national environmental planning, and public health. It was, in many ways, a storm that was centuries in the making, highlighting the existing vulnerabilities of the Gulf Coast. In the 1970s, researchers began to term this area of the Gulf Coast, really from Florida to Texas, encompassing the states of Florida, Alabama, Mississippi, Louisiana, and Texas. And you really could include Oklahoma in that, as well as the stroke belt, noticing that this particular area of the country had a higher than usual percentage of individuals who were suffering from stroke, who were hypertensive, who were suffering from obesity and diabetes. And this area became known as one of the most unhealthy corridors in the United States. Leading up to Hurricane Katrina, the Gulf Coast had higher than average rates of obesity and diabetes, and among the highest rates of poverty in the country. And so all of these sort of questions or issues are part of how we think about and how we remember Hurricane Katrina. And talking particularly about two aspects of Hurricane Katrina, and there were a number of chronic diseases that were front and center in how we remember and think about Hurricane Katrina. At the time and after, we've sort of termed these individual special needs populations, individuals who were connected to technology, who were immobile because they were connected to technology, immobile because of their chronic status, whether that was cancer, asthma, diabetes, hypertension, or dialysis. These were populations that were uniquely vulnerable in the aftermath of Hurricane Katrina. And dialysis is an example of this. people often ask me how I became interested in diabetes, and it's really quite organic, to be sure. I was finishing my dissertation on the 1927 Mississippi River flood when Hurricane Katrina occurred in 2005. And I was pulled into these conversations about Hurricane Katrina and special needs populations. And I remember one of my colleagues gave me an editorial from a newspaper in San Diego. And that newspaper editorial read that somewhere, presumably in a cave, Osama bin Laden could get dialysis if he wanted it. But in New Orleans, people are giving dialysis patients and diabetes patients fruit punch to stave off diabetic shock. And that was particularly telling for me. And I began to really sort of think about this question of dialysis and diabetes. And dialysis is one of the complications of diabetes in the form of end-stage renal disease or kidney failure that is the most serious, along with heart disease and stroke. And I'm also currently writing an article on the first outpatient dialysis center in Seattle, the Seattle Artificial Kidney Center. But interestingly enough, dialysis is one of the things I do not think we have given enough attention to in this current conversation around COVID, particularly when you think about dialysis individuals who must leave their homes 3 times per week. People who are on dialysis usually go into the center Tuesday, Thursday, and Saturdays without fail. We don't normally think of dialysis as life support, but in many ways it is a form of life support. And so whether there's a quarantine, whether the COVID is raging, those individuals have to get out in the streets. And in New York City, brave public transportation, some of them. There are a lot of transportation systems for dialysis patients, but some of them do have to get on public transportation, which in itself can be dangerous. And so during Hurricane Katrina, dialysis patients were particularly vulnerable. The storm really hit New Orleans and the Gulf Coast Monday, August 29th. And throughout the whole city, during the height of Hurricane Katrina, there were only 3 dialysis centers out of roughly 28 that remained in operation throughout the entire storm. Tulane Hospital began seeing dialysis patients the weekend before, understanding that they might not be able to see dialysis patients throughout the entire storm. There was evidence, and this evidence has become truth, that for patients who miss 2 or 3 sessions of dialysis, they are more likely to end up in an ER or hospitalized. And so Tulane Hospital sought to go around this by bringing patients into the center and giving them extra sessions that Friday and Saturday before the storm. But Monday evening, Tulane Hospital lost power. Monday Tulane Hospital lost their water supply, or the water system. And potable water is a necessity for dialysis. And so they essentially had to stop doing dialysis by Monday evening. By Wednesday, they lost all power and had to begin to send all of their patients to New Orleans Superdome or to other shelters. Dialysis is also important for thinking about how people are evacuated. It's difficult to evacuate individuals who are on dialysis because advanced planning is necessary and is important. And so dialysis patients in many ways would become the symbol of vulnerability for the storm. Diabetes or diabetics were also a vulnerable population. You see these images of supplies, but also individuals who were suffering. And part of what I'm arguing is by the latter part of the aftermath of the storm, people began to really think about the unique special needs population of diabetics, But throughout most of the evacuation period, diabetics as a special population was largely ignored, or people did not give enough thought to what diabetics in particular would need. And part of that revolved around diabetics' inability to control their own environment in shelters. As we talked about earlier, what differentiates diabetics from other chronic disease patients is that diabetics have to self-manage their disease. There's a certain amount of self-surveillance and self-actualization in the form of maintaining diet, eating on time, injecting themselves with insulin on time, making sure that insulin is in good shape. So there's a lot that goes into being a diabetic that when there's a disaster, that sort of chorus can easily be disrupted. For diabetics during Hurricane Katrina, they were unable to control their eating habits. Most of the food that would come to these shelters were high in sodium, high in salt intake, high in fat. And many of these individuals had no choice but to consume these foods, even if it led to higher glucose levels. It was difficult for them to eat on schedule based on the amount of people who might have been in line before them, based on how they were feeling. Sort of the stress of being displaced might have caused them to lose their appetite. But by not eating on schedule, they risked going into diabetic shock. So all of these issues were important, as well as insulin as well. Many of the individuals who ultimately ended up in the New Orleans Superdome brought insulin with them, but there was no guarantee really that there would be insulin in these shelters, and most did not have a supply of insulin. There was really only one shelter, which was the Baton Rouge shelter, which was outfitted for diabetics early in the evacuation process. For the most part, or when possible, they tried to evacuate diabetics to certain hospitals that were continuing to take patients. But many of them nonetheless ended up in high school gyms, the New Orleans Superdome, and the Convention Center. And so you have this issue of injecting insulin for many people. They ran out of insulin. When insulin supplies were shipped, it might not have been the type of insulin that they were taking. It might not have had the right dosage. When medical records were subsequently lost, physicians, scientists, helpers had to rely on the memory of traumatized individuals to tell them what kind of insulin they would normally take. And so all of this was in many ways a guessing game, and proved inadequate in terms of what was required to help deal with this population. Syringes were hard to come by, and even when insulin was shipped to the Gulf Coast, there could also be a problem with refrigeration. Refrigerators were not often or not used in tremendous supply. People had to find ice to keep insulin at the proper level. And so all of this then required a certain amount of planning. And so many health scholars have argued that diabetics, health costs of diabetics during an immediate aftermath and long-term aftermath of Hurricane Katrina was in the range of $504 million in terms of life expectancy, reduced life expectancy, and hospital costs. One other aspect of this disaster for diabetics was that sort of stress levels, lack of medication, lack of proper eating habits led to increased rates of hospitalization for diabetics in ERs in New Orleans, but also in the Gulf Coast, but also in other states as well, which is very important for us to think about in our current moment. And in that particular moment, and during Hurricane Katrina and its aftermath, there was also this phenomenon of this hidden epidemic of diabetics, where people would end up in the emergency room for one or a number of reasons. And they did not know until they were in the emergency room that they were actually diabetic. And so that's a phenomenon that we're actually seeing now as well during the current COVID pandemic. People are being diagnosed with diabetes, type 1 and type 2 diabetes, while hospitalized for this current COVID pandemic. So there are a number of stories that are important for us to think about with Hurricane Katrina. In an essay that I recently published in the journal ISIS, I talk about one particular woman who was pushing her elderly brother through standing floodwaters for a mile to the Pontchartrain Expressway in the hopes of being evacuated to one of the shelters. Her brother was a diabetic, had also suffered from a stroke, and was unable to walk. And just want to take this moment to just sort of reiterate how difficult it is to push a grown man through standing floodwaters. That's a difficult thing to do for an entire mile. And she got to the Pontchartrain Expressway and was told that no one was coming to get them. And so they had to walk another mile to the New Orleans Superdome. Another woman wanted to try and walk to the Pontchartrain Expressway, but could not do so because her feet had swollen, and she didn't think that she would make it and didn't want to fall in the floodwaters. And so there are also these narratives of what complications of diabetes meant for those evacuating in the form of access to dialysis, limb amputations, blindness, but also skin. One of the complications of diabetes is diabetics have to pay particular attention to breaks in their skin, scabs, which can lead to gangrene and also amputations. So when there are these open wounds on the skin of diabetics and they're wading through this ooze of flood waters with toxic materials and sewage and corpses, remains of corpses floating around them, this was particularly disastrous for those individuals. And you have a number of testimonies of Katrina survivors. Tuesday evening, my neighbor Kip, kidney transplant patient, waited home alone by flashlight from the convention center, where there were neither dialysis machines nor buses to get him to one. A nurse at the United Rehabilitation Hospital, several diabetic patients have been without dialysis for nearly a week. After the fruit cocktail and peanut butter ran out, they broke into the candy and drink machines for sugary items to keep patients from going into shock. These are people who are not going to make it. Another testimony, a frail fellow, a diabetic whose limbs are too swollen to walk, unable to obtain dialysis, treatment for a week, being pushed along in a wheelchair by an elderly friend. So you hear all of these stories about giving people fruit punch to stave off diabetic shock and breaking into vending machines to prevent this shock. These stories are fairly common in the aftermath of Hurricane Katrina. But it's important to also understand that hospitalizations after disasters is not unusual. I could even go back before this, but a few recent storms, relatively recent storms, in which there was a connection between a crisis and elevated risk factors and ER visits. Tropical Storm Iniki in Hawaii, Hurricane Andrew, Hurricane Marilyn, and the Virgin Islands, Hurricane Charlie. All of these disasters led to increased hospitalizations for diabetic patients. And so it's important for us to think about this history in the current crisis and the current process. Increased ER visits as well after the Kashmir province in India earthquake in 2005, the Chicago heat wave in 2005, and the Southern California heat wave in 2006. So how do we then think about COVID-19 and environmental disasters? One thing is for sure, the world must contend with environmental disasters in the form of hurricanes, tornadoes, floods, earthquakes, and other disasters. This threat does not change because of a pandemic. One of the ways that we now think about disasters, for example, and it sort of goes back to this change from a local disaster to more of a national disaster, is that in the aftermath of disasters, it has become a collective enterprise. Meaning, if there is a tornado in one particular state or a hurricane in one state or region, we usually expect first responders from neighboring states to come into that affected region. Firefighters, health professionals, volunteers. All of these individuals move in and out of these devastated spaces in the aftermath of disasters. But the current COVID-19 pandemic makes that tricky. It requires much more planning and thought in a way that I'm not sure that we have given this unique scenario of thinking about how we will go about lessening the risk of spreading the COVID-19 pandemic in the aftermath of a disaster. What are the protocols for dealing with individuals who will likely need to be rescued, but also placed in shelters? How are these shelters going to try and prevent the spread of COVID in the shelters? What about individuals moving from one state to another state, or one region from another region in the midst of a global pandemic when some states may or may not be in quarantine or lockdown? These are all of the questions that really around March, people began to think about when it was clear that this was going to be a long-term, a year, possibly longer, probably longer event, that we had to begin to think about what it meant when disasters collide in a way that's not only possible, but inevitable. And we have already had one disaster, which was kind of not covered extensively, because this was in many ways beginning of height of sort of the pandemic in March. But a 5.3 scale earthquake hit Croatia a couple of months ago in March, killing at least one young girl, a 15-year-old girl, but possibly others. And this image, which is sort of very interesting, because you see the mixture of two disasters of individuals wearing gloves and masks walking through the rubble of an earthquake. And one woman who was able to get out of her home unharmed said in response to a question about the pandemic, she said, well, in this kind of event, you have to get out of your home and save your life first, and then worry about trying to grab a mask later. In some ways, in many ways, that's understandable. But what it does show is that what that does show is that planning is required and necessary to be able to deal with this collision of disasters, and how we think about sort of a pandemic in the midst of an environmental disaster. And our last slide is about this sort of question of foreseeable disasters. Earthquakes, tornadoes are likely to come, but there are some disasters that we know are coming. More recently, we might think of forest fires as a foreseeable disaster in the sense that this is something that we fight every summer for the last couple of years. And with forest fires, you normally have firefighters, first responders coming from all over the country and sometimes all over the world. every day getting on a bus, with all of their equipment, going to fight this fire for hours at a time, going back to the campsite where you would normally have 15, 20 firefighters, first responders in a camp, sharing kitchen, sharing porta potties, sort of sharing all types of other sort of common equipment. That's not really necessary, or that's not really something that we can do at this particular time. And so what does that mean in terms of how we continue to fight these seasonal forest fires that hit Arizona and California seasonally? Winter is coming. Sort of what are the ramifications of power outages? Sort of individuals who are sort of seeking shelter from inclement weather. All of these issues are likely to elevate the risk of diabetes and comorbidities, and heat waves. Heat waves are for me sort of a yearly disaster, which we really don't give enough attention to. I think about Eric Klinenberg's work on the 1995 Chicago heat wave, in which he describes this social autopsy. Heat waves are interesting because they don't usually produce these visually fantastic images that we normally associate with a disaster, but they come every year. Heat waves are a disaster that we can plan on every year. And for some people, in Eric Klinenberg's book, he talks about individuals, poor people, elderly, who have outlived, in many ways, their social infrastructure and network, who had to make a choice in living in these high-rise apartments. They either had to pay their rent or run their air conditioner. Many of them did not have the money or the resources to do both for an extended period of time. So for some of them, they decided to pay their rent and did not run their air conditioner and died in what were essentially hot boxes on the 15th or 20th floor of a high-rise building. And lacking family and infrastructure, the only reason that their bodies were found was one or two reasons. One, the rent was due, or two, the bodies began to decompose and smell. And so Eric Klinenberg is sort of arguing for this social autopsy. What does this tell us about the social dynamics of American life, sort of spatial arrangements, poverty, class? One of the things that people normally do in a heat wave is come outside and spend more time outside. For elderly individuals and for all of us, that may or may not be an option and can be dangerous. So how do we think about that? How do we sort of plan for that during a global pandemic? And so these ideas require some planning, and it's something that in the midst of sort of climate change and other sort of disasters that diabetics and other chronic disease patients will be vulnerable to increasingly in the next year and beyond. So with that, I will stop, and thank you so much for your attention out there in Zoom land.
Thank you so much, Dr. Mizell. Do you mind culminating the screen share so that we can reconvene here as a little circle?
Sorry about that.
Excellent.
Yeah.
Oh, thank you so much. Yeah, so I'd like to open this up to sort of a free-form conversation, which will be less free-form than if we were all sitting around the reading room in the library company where we could sort of see each other and pick up on each other's visual cues. So I will invite folks to use the Q&A feature if they have questions that they'd like us to engage. And certainly we have a couple of additional experts on this particular Zoom. We have Gigi Pierre, and we also have Christoforos Sassaras, who are both Mellon scholars that have generously agreed to also participate in this. They were in that infectious disease themed curriculum that was just completed. And so I'd love to invite them to participate in this conversation. But in the meantime, I'd like to sort of just open it up with sort of an open-ended question that maybe brings your work on diabetes into contact with COVID. Because one thing that I'm interested in is this idea that diabetes is self-managed, right? So that is, necessarily an individualistic sort of imperative. And yet, when you're talking about the sort of history of federal intervention, which really begins in the 50s and 60s, that's really about the federal government coming in to help individuals through disasters. And what if there's a tension that's revealed by something like diabetes between that sort of federal imperative to think strategically about sort of long-term planning and systems and that sort of individual charge to think about your behaviors, and whether there might be a way to draw then diabetes together with COVID, which includes a lot of self-management in terms of, mask wearing and social distancing and so forth.
Yeah, I think that's an interesting point. I think that reality is diabetics are forgotten in this narrative because we don't really think about the self-management part of it. And I think that's the issue. And I think that there are a lot of narratives coming out of leadership positions, to say the least, and that's putting it lightly. But I think that what is required for diabetics is an understanding that they have to self-manage their disease, but they still need help from those individuals who are in a position to provide resiliency or help to build a resilient community. And that's a term I really didn't use that much, but how do we build resiliency for certain communities? And I do think that is the responsibility of the government, of the federal government, who is charged with protecting citizens' lives. So unlike other groups of people, diabetics have to do some of this themselves, but in certain circumstances, it's difficult for them, if not impossible, for them to do so without help. And when I say crisis, I mean, I can sort of think of a number of things. I mean, even just losing your job can be catastrophic. I mean, losing your job can be catastrophic for everyone, of course. But when I was writing my recent essay, I was doing so in the wake of the government shutdown, right? And so I was thinking about this question of the government shutdown in terms of diabetics and how they might manage if they were, how they might manage this particular disruption. So I think that it's for us to really understand the unique position of diabetics, we have to acknowledge that even small disruptions can have a disastrous impact on their daily life.
It looks like Kim Nielsen is sort of following my thread here. She asks, well, first she thanks you for this marvelous presentation, and I second her on that. She asks, what should we take away from this very sobering presentation about how to manage both individually and corporately COVID and the people it impacts today?
Well, I think that, information is important, but I think on a practical level, I think that it is important for us to begin stockpiling, insulin, stockpiling diabetic foods. Those individuals who are suffering from diabetes, but also state governments, local governments, federal government, is required for us to, if we are serious about dealing with this population group during a disaster, that we have to plan. We have to plan for the inevitability of disaster. Understanding that when people move, that they might have to socially distance. But if they can do so in a pandemic, if there's planning that has been put on the table in a way that's serious and determined to deal with this particular situation. So I would say sort of planning is important, but understanding sort of what each individual diabetic must go through to ensure their own safety and their own health. And of course, each individual diabetic is different in terms of how they manage and what's required to manage their disease. And part of what I talk about in that essay, which was published in March, is that the American Diabetes Association, American Association of Endocrinologists, American Public Health Association, they have all begun to really think about this situation and to help prepare diabetics for this inevitability of disaster by helping them to put together diabetes kits, which has their most recent A1C level, syringes, but also their medical records, whether they're type 1 or type 2, the names of their physicians, names of their nurses. All of these issues are important. On a much broader scale, I do think that this question of generic insulin continues to be important because insulin is very expensive. It's hard to stockpile, it's hard to prepare for being out of a job for a month or 2 months with the price of insulin and the price of other diabetic drugs. And so this question of cost, and insulin has always been expensive from 1922, 1923 to today. It's exorbitant for many people, and that's something that I think we have to address.
So we have a question here that asks you to sort of make the implicit explicit. So you've talked about, poverty, you've talked about the sort of conditions in Katrina, but I wonder if you can also sort of get back to sort of the theme of this seminar, which is, what does this have to do with race? And are there any connections or lessons you can draw from your study of diabetes to infectious disease more broadly?
Yeah, well, I think that we still have an unwillingness to sort of think about these broader questions of race, and diabetes as a particular disease has often been racialized. And so even though we have this sort of long-standing narrative of racializing diabetes from the turn of the 20th century to the present, and sort of at one point, diabetes was, again, considered to be a white disease. By the latter part of the 20th century, type 2 diabetes was considered to be a Black disease. So implicit with this conversation of COVID and diabetes is this perception that it's a Black thing, right? That people who are suffering from COVID-19 through this underlying condition of diabetes is suffering through their own fault, through bad eating habits, through poor choices, and that COVID is not the blame, but the poor choices of African Americans are to blame. And so once you begin to have this narrative of diabetes being attached to COVID, or diabetics being particularly vulnerable to the COVID virus, the narrative nationally began to shift. For some people, it became less of a threat because the perception was that diabetes was something that only African Americans suffer from, and therefore white people were not as vulnerable to COVID. And so that goes to a much broader discussion, of course, which is this lingering perception that only African Americans suffer from diabetes. When I give these talks, sometimes or in lectures in class, I often get people who come up to me and white diabetics who would say something to the effect of, I didn't realize I could get this disease, or I didn't know that my grandfather could get this disease. We were all shocked and appalled because there's this broader image which tells us that white people are immune from diabetes and therefore immune to, in this context, possibly COVID because of their immunity to diabetes. Is sort of how this sort of perception, narrative, miscommunication can be construed.
That's great. We have a question from Veronica Watson. Thanks you for this provocative talk. And she says, I'm wondering about the widely available social narrative about diabetes. Yes, about diabetes being about self-control, or is that something that arises in populations with a lack of self-control? So yes, it's about the reality of managing the disease, but are the issues you're calling attention to also complicated, compounded, or even supported by a larger narrative that type 2 is something that is largely avoidable? What a great question.
Well, I think that it's clear that eating habits, choices can have an impact on rates of diabetes, but that's not the only aspect, right? So type 2 diabetes in particular is a mixture of possibly genetic, social, and environmental circumstances. And so each of these particular circumstances can result in why a certain person has diabetes. Part of what you see by mid-century is this sort of push to understand this changing dynamic of diabetes and why it's shifting within science. And quite frankly, part of that comes up because of this longstanding unwillingness to see diabetes, right? So clearly African Americans were suffering from type 1 and type 2 early in the 20th century, but that was being ignored. Civil rights era really sort of highlighted, along with cancer, along with asthma, this so-called hidden epidemic within African Americans. And so scientists had to explain that away in a certain sense. And part of how they explained that away was that was through this narrative of personal choice. And so this idea of personal choice was very political and used for political reasons, but it was not applied equally, right? So, even for those who were white and had type 2 diabetes, you didn't see the same narrative of politicization or sort of choice around it. So I think here is a moment where you see sort of the political and the biomedical converge in a way that is used to explain disease or explain the sudden outburst of disease in a way that's been long ignored. And so the reasons for that are just as important as sort of how we think about it.
Well, that actually brings me to a question that I have for you, if you'll indulge it, which is, you sort of began this talk by saying that disasters mark time. Mm-hmm. I wonder if the way that we talk about disasters, the stigmas that we associate with given disasters, can help us to draw some continuities across time or between disasters. Like, are you seeing, with the way that we talk about Katrina, for example, or COVID for that matter, something from the contemporary, do you see a sort of historical parallel if we go back to the 1918 flu pandemic?
Yeah, I mean, I think that there's a certain playbook. I think that there's continuities and changes, but one of the continuities is again our desire to assess blame, but also in sort of what comes afterwards in terms of what we expect. I think that my experience with environmental disasters is that in the immediate aftermath of disaster, there's this momentum, right? There's this energy that we're going to bring about significant change. And it does occur in many ways on local levels. After the 1906 earthquake, for example, the city government in San Francisco was able to put forth these long debated public infrastructure changes in the form of, paved streets and lighting. And so in the aftermath of just about every major disaster, you have this sort of energy of what's coming next, this sort of modernization that society is going to change for good. In the aftermath of Hurricane Katrina, as I mentioned last time, there was conversation of this new war on poverty that was going to, significantly transform American society, that was going to transform sort of infrastructure of American cities. But I also think that one continuity between disasters is that we have a short memory. We move on quickly after a disaster is over, which of course is another conversation about when disasters, epidemics, pandemics, or environmental disasters end. But once we move beyond sort of the immediate threat, then we begin to lose interest. And so I'm cautiously optimistic, as I said the last time I was here, that significant change can occur socially, politically, economically in the aftermath of this COVID pandemic. But I'm also cautious because of what I have seen in the past and our willingness and desire to move beyond these moments in a way that shows willful ignorance.
Yeah, it's heartening to hear you talk about the possibility for reform, because when I think about Katrina, when I think about what we've seen so far of COVID, I see failure, failure, failure. And I see something where you have a disaster that reveals the fissures and limitations of the system that we have in place.
Yeah,
Um,
yeah.
and I just wonder if, like you tell a story where, basically since 1960, the federal government has gotten more and more involved. And I feel like what's happened in the past several months is we've sort of pulled back the rope and we've seen the limitations of that charge, particularly when you have a federal government or, folks in charge of a federal government that actually don't want that authority. Is it possible that, the pendulum is swinging back and we're going to be moving back towards more of a localized response?
Well, yeah, I mean, I think that is a possibility, unfortunately, at least under this current administration, which is decidedly anti-science, which, that in itself is not original or new. There have been societies in the past that were sort of anti-science. But I think the problem with the localized approach for this pandemic and even for disasters is that it leaves too many gaps, right? I think that for some of this stuff, what we're doing in the aftermath of this COVID pandemic, the federal government is necessary. It was necessary for these PPE equipment. It's necessary to coordinate different responses, vaccines. But it's really a sort of a false dichotomy in many ways to think about, or it's really sort of unfortunate in the way that this response has become localized in a sense that where the power of the federal government is not used and not sort of understood to be valid. But going back to your previous point, I would also argue that one of the ways that we think about sort of this continuity really is in the form of charity, right? I think that one of the continuities between the 1927 flood and Hurricane Katrina was this sort of lingering resentment and mistrust of the American Red Cross, right? So African Americans in the aftermath of the 1927 flood understood that the American Red Cross was an organization that did not have their interests at heart in terms of the evacuation, but also resources available to African Americans in the aftermath of the disaster. So African Americans circumvented the Red Cross and sent money to the Mississippi Delta via church groups, through organizations, fraternities, sororities. And that was really one of the legacies in the aftermath of Hurricane Katrina, that there were all these faith-based organizations and groups that emerged to help deal with evacuees and disasters. And so I still think that there's a historical mistrust, well-founded, of the American Red Cross in ways that's historical.
That's great. So we have a couple of questions that are coming in offline from our two Mellon scholars, Christophorus and then Gigi. So I'd like to ask Christophorus, do you want to turn off your video and unmute yourself and pose your question directly?
Oh, I was muted, sorry. So my question was about one of the things that I tend to think about, in relation to diseases is the role of insurance and insurance companies and how that, how that topic fits into this discussion, either in relation to diabetes or more generally. I'm interested in hearing about that. Sorry, I know it's a very broad question.
Yeah, it's funny you asked that question about an hour before I got on. I saw a story on CNN of a police officer who was denied insurance, who died from COVID, and the insurance company essentially refused to cover his death. And of course, that's always an issue in the aftermath of disasters, environmental disasters, and one of the protections of the Affordable Care Act is that it gives access to pre-existing conditions or provides insurance accessibility to those individuals with pre-existing conditions, including diabetes. And so it would be devastating to repeal that mandate because it would leave so many people out in the cold. So I do think there's going to be a battle, not immediately down the line, in terms of insurance companies and what they're going to cover and what they're not going to cover, whether it's a COVID death or a COVID-related death. I mean, that's another point that I didn't really get into. In the aftermath of Hurricane Katrina, you had this narrative of COVID-related deaths, people who may not have immediately died from the storm, but died from heart complications, other complications, maybe a year or 2 years, 3 years down the line, so that they were not included officially in Katrina death tolls, but in many ways they were a Katrina-related death. What you're already seeing are individuals who are suffering from COVID-related deaths, right? So they may not have immediately died from the COVID virus, but maybe scarring of tissue, maybe lingering cardiovascular issues, some difficulties with comorbidities, chronic underlying conditions that were exacerbated by the virus has caused their deaths a month down the line, and may continue to cause deaths months or even years down the line, and how insurance companies sort of think about these questions. I think that will be an important terrain and battleground as we move forward.
Thank you.
Thank you, Christophorus. Gigi, may I ask you to join the conversation?
Hi. Mine wasn't necessarily a question, it was more of a comment. And I just really want to, the part where you were discussing, you know, where you're showing the art, the propaganda of battling diabetes, that's the information I never knew that diabetes was taken that seriously, that they actually had propaganda towards it. Because if we speak of diabetes now, it is like it is considered, you know, not a natural dangerous disease or anything, something that could be managed. But I was definitely unaware that there was that much focus and that much resource, not necessarily resources, but you know, just a way to basically tackle it in that way.
Are you referring to the cartoon or?
Yes.
Oh,
yes.
okay.
I was definitely unaware because if you think about the AIDS and pandemic, like there were cartoons, there were like, you know, commercials directed towards it. So a lot of major diseases have always had certain propaganda to go with it. I was never unaware that diabetes was one of them. Because like if we talk about diabetes now, it's not something that is majorly considered as a threat. You know, it's literally has been, like, I don't want to say watered down, but it's not considered something that should be primary focus. But then when you were discussing, you know, the effects of diabetic patients in Katrina, once again, this is information I've never ever known about. Like, today's the first day I'm sitting here like, what is going on? And you know, and you're relating it to our current situation. I'm like, oh my God, he's making absolute sense. So it was just like I was taken back because, like I said, I was unaware. I was absolutely unaware.
Thank you. I appreciate that. Yeah, I know. You see this, I mean, this ADA diabetes forecast, and the American Diabetes Association was established in 1941. So particularly after 41, you see a lot of curriculum and material coming out of the ADA, trying to inform people of diabetes. And, you know, diabetes is, when it transformed into a chronic disease, it had a lot of stigma. So you had people, part of what I talk about in my book is this notion of people hiding their disease, hiding their status. So people hid their status from the employers. You know, if you wanted to work for, I mean, I have records of people who were working for an insurance company, you know, traveling insurance company, and they were fired once their status was revealed. People had to get a doctor's note to keep their jobs or to get a job. Husbands hid their status from their wives, and vice versa. Elizabeth Hughes, who was one of the first patients to get insulin in Toronto, hid her diagnosis for her entire life. People didn't know that she had diagnosis until she was an older woman, for fear of being stigmatized. But on the other side, there was also this narrative that in many ways was presented by Elliot Joslin, which was this sort of conversation of diabetics are model citizens. They're better than most because of what they have to go through. And so you see this sort of literature. Basically what undergirded that cartoon I showed you was this sort of idea of diabetic patients being model citizens, but also worthy, unworthy sufferers. In almost patriotic terms, you know, worthy diabetics followed insulin requirements, ate on time. Unworthy diabetic patients did not follow insulin injections properly. Of course, one of the things that Elliot Jocelyn Gardsley does not take into consideration are some questions of race and class. And for someone who's a sharecropper in South Carolina who's a diabetic, it might be hard to, follow insulin injections and eat food on time when you're poor to begin with and you're eating a diet of meat, meal, and mush. So, these are some of the broader questions and implications that my book raises. So I appreciate you. I appreciate your question.
Yeah.
Thank you
both for participating in this. I really do appreciate the fact that you probably know a lot more about this than your typical seminar participant. So I really do appreciate you contributing to the conversation. I want to be respectful of everyone's time, so I think I'm going to start to wind us down here. First off, I want to thank Dr. Richard Mizell. Thank you so much again for agreeing.
Thank you, I appreciate it.
This. I feel very privileged to have a sort of first preview of research that you're working on actively right now, and I'm really delighted that we could host this, even though it's not sort of like the typical library company conversation. We rarely get into the 20th and 21st century, but I'm delighted that we had an opportunity to do that with your research.
Yeah, and I told Christophorus this, and Gigi, if you have any questions about graduate school or anything, definitely let me know. I will try to recruit both of you at some point, but I'm going to make it up to Philadelphia. I was supposed to come last year and couldn't come, and of course couldn't come this year. So one of these days I'll get up there.
Excellent. Well, I'm hopeful that we can all do this in person in the not too distant future. Until then, we're going to continue along our online trajectory for the third and final session, which is going to happen 2 weeks from today, same time, same place. That'll be led by Dr. Samuel Kelton Roberts Jr., who's going to be talking about something that's more of our library company bread and butter, the cholera epidemics. And he's going to consider how urban political economy and racial sciences produced devastating health inequalities then and today. So thank you so much for choosing to spend a little bit of your Wednesday evening with us, and look forward to seeing you on our next Zoom.
Thanks, everyone. Appreciate it. Thanks.
Thank you so much.
Thank you.